If you've been experiencing symptoms like heart palpitations, joint pain, and mood shifts, and your doctor keeps circling back to it's just stress or aging, here's what often gets missed. Both estrogen and progesterone hold up far more than just your reproductive cycle. When they shift, what surfaces is often what your body was already quietly managing underneath the surface for some time, in places no one thinks to connect. I'm Dr. Kenny, an IFM certified functional medicine practitioner, and in this video, we're going to walk through the perimenopause symptoms that most people are not connecting, especially early on, and why the hormone drop is a huge part of the picture. Here's the frame that I want you to hold for the next 15 minutes. Think of estrogen and progesterone as your floor, a baseline that your nervous system, your immune system, your connective tissues, your microbiome, and your cardiovascular system all rely on. When that floor begins to shift in perimenopause, what gets revealed is everything that was already sitting on top of that floor in each and every one of these systems that was being quietly held up by the protective properties of estrogen and progesterone. And I want to be very clear here because many people have probably experienced this exact same thing. The hormone shift is real and it's significant. And it does directly cause some of the symptoms that you may be experiencing. But the reason two women can have nearly identical hormone panels and completely different symptom burdens, one woman managing the transition relatively smoothly, while the other feels like her body has become unrecognizable, that reason lives in what each woman was already carrying before the hormone shift began. It's all relative. Think of it this way. Imagine an iceberg. What you can measure on a lab panel, estrogen levels, progesterone levels, that's just the tip of the iceberg. Underneath the waterline is everything else, and it's 6 main areas I want to talk about. Number 1 is how your body is even processing or metabolizing these hormones throughout life and today. Also, what your stress chemistry has looked like over the last 10, 20, 40, 50 years. How much your nervous system has in reserve. Also, how much environmental load you've been managing throughout your lifetime. Number 5 is what your microbiome looks like throughout life and today. And then lastly is what your genetic tendencies are around enzyme function and processing or detoxification. The tip of the iceberg, of course, matters, but the iceberg underneath is what determines how hard the transition hits for many people. So as we talk about some of these symptoms, and we're going to go through many, including those that you've probably never heard of or connected to hormones, I want you to hold 2 questions at once in this process. Number 1, what is estrogen actually doing in the tissue? And number 2, what was the system already managing before the shift began? Both questions matter, and the first one is where many conversations stop in perimenopause and menopause. The second one is really where the investigation begins. A large review of research confirms that even the best characterized perimenopause symptoms, like the hot flashes, the vasomotor symptoms, affect somewhere between 50 to 75% of women going through the transition. A meaningful portion of women in perimenopause do not fit the textbook picture at all. That heterogeneity or differences is the point. So the big takeaway is that symptom burden in perimenopause is real and wide-ranging, and it varies considerably from woman to woman. The variation in who experiences what and to what degree goes beyond what a basic hormone level blood panel can explain. And by the way, I've put together a free research summary that goes deeper into the mechanisms and the research that I used to create this video. So if that's interesting to you, check it out. It's in the pinned comment and the description below. So let's anchor into the idea that the nervous system is downstream of estrogen. And let me explain why this matters neurologically, because this is the piece many explanations shift. Estrogen receptors are distributed throughout the nervous system. They sit on your neurons, in your brain, in your spinal cord, in your auditory pathways, in the sensory nerves that are running through your skin. These are structural, physical connections. And when the hormonal signals, those receptors in the nervous system have been reading for 30, 40 plus years become volatile, unpredictable from week to week, the nervous system has to recalibrate everything it was using estrogen to regulate. What researchers have found is that the menopausal transition also triggers a systemic inflammatory shift. And that is so much more than just a hormone story. In fact, a review in a peer-reviewed neuroscience journal showed that perimenopause disrupts estrogen-regulated systems, including the innate immune system and mitochondrial function, all the way down to the cellular level. Mitochondria, by the way, are the energy-producing structures inside each and every one of your cells throughout the entire body. And estrogen has a direct regulatory role in keeping them running efficiently in the brain, the nervous tissue, and every cell of the body. What this means is that estrogen has been acting as a master regulator across your entire nervous system and every single cell of the body. When its signaling becomes unstable during perimenopause, the downstream effects show up far beyond hot flashes and mood shifts and cognitive changes. There's pain sensitivity and immune reactivity or lowering of resilience. Each and every one of these signals are the nervous system reporting that the hormone context that it was operating in for decades has shifted and that it's recalibrating under a new load. They share a mechanism, which is why they often arrive together. So coming back to the idea that two women can have completely different experiences, what each woman is bringing to this transition and this hormone shift, how sensitized her nervous system already is, or how much accumulated stress burden it's been carrying throughout the years. Even how much the underlying infrastructure, such as the mitochondria, has in reserve. These shape how loudly those signals fire. I've sat with many women in their 40s, 50s, and 60s, and when we map their timelines, when did this start? What was happening in your life in the years before? What I see consistently is how much they were carrying and normalizing long before the hormonal shift made it possible to ignore. That shift in the hormone floor is what reveals a load that was already there. There was some interesting research that looked at how withdrawing estrogen changes the way the brain perceives pain. And it found that serotonin, adrenaline, and the opioid signaling at the level of the limbic system, this is the part of the brain that's involved in emotion and pain regulation, all shift during this transition. What this means clinically is that the nervous system's threshold for registering and amplifying symptoms can drop during perimenopause. The brain and nervous system become more sensitive, and sensory symptoms or mood shifts and pain sensitivity often cluster together in this transition because, again, they share a similar mechanism. So here's another few symptoms that sometimes have my patients bouncing around between specialists without connecting the dots. Number one, tinnitus, that ringing or the buzzing in the ears that seems to come out of nowhere, high-pitched or low-pitched for some. And it's one that I hear about constantly. Estrogen receptors are found and distributed throughout the nervous system parts of your ear. This is very sensitive nerve tissue that carries signals from your inner ear to your brain to be processed. Again, when estrogen signaling becomes volatile, the auditory nervous system can become more sensitive and less well regulated. And in my experience, women often report that their tinnitus tracks with their hormonal fluctuations. When I hear a woman in her 40s describing tinnitus that came on without any clear hearing loss, or that doesn't respond to Epley's maneuver, which is a specific maneuver for the physical shifts in the ear that can cause ringing, their hormonal terrain is a consistent part of my thinking. Palpitations are another symptom, that heart racing or fluttering sensation, often at night or when you're at rest or during periods of a hormonal shift. Progesterone receptors are expressed in the cardiac tissue in higher amounts. Estrogen also has direct effects on the blood vessel tone, meaning how flexible or responsive your blood vessels are. When these hormones fluctuate, the autonomic nervous system, or the part of the nervous system that is not under our control, that controls your heart rate and your blood pressure without you even thinking about it, loses some of its buffering. Again, the floor. The result can be palpitations that are genuinely uncomfortable and disturbing anytime anything's going on with the heart. These are real cardiac sensations and they deserve to be investigated, so definitely do so. But for many women, the investigation that matters the most is the hormonal and nervous system pieces. alongside the cardiac workup. Joint pain is another symptom that surprises many that comes alongside this hormonal shift. Estrogen has anti-inflammatory properties, and it plays a direct role in the way your joints produce fluid and the health of your connective tissues. When estrogen drops, joints lose some of their lubrication and that inflammatory protection. Women often describe this as feeling like they've aged 10 years in 1 year. The knees, the hips, the fingers, places that may have been quietly vulnerable for years based on their lived experiences, but they become symptomatic when estrogen is no longer holding up that anti-inflammatory baseline. Then there's itching of the skin or crawling sensations on the skin. This tends to generate a lot of confusion and sometimes dismissal as well. The clinical term is called formication, a sensation that something's crawling under the surface of the skin. And estrogen receptors, guess what, are present in the skin. They regulate hydration, collagen production, and sensitivity of the nerve endings there. When estrogen fluctuates, those sensory nerves can become overactive and poorly regulated. This is that same nervous system sensitization mechanism we just walked through, but playing out at the surface of the body for the same systemic reason. This is why everything is often connected. And then the mood shifts round out this picture. And though this is more common, oftentimes patients are going through a clear mental health workup rather than also considering hormones. And I see that all too frequently. Specifically, these mood shifts are the ones that feel qualitatively out of character from what the woman has ever experienced before. It can show up as anxiety or depression or irritability that comes and goes just as quickly. These presentations often reflect the systemic inflammatory dimension of perimenopause, that shift in serotonin signaling or noradrenaline/norepinephrine signaling, combined with the nervous system carrying a higher baseline load than it could carry quietly before. Now, I want to spend a moment on an area I'm particularly fond of, and these symptoms often share an upstream driver, which is why I want to share this mechanism. And to explain it, I want you to think of a garden. A garden depends on the resources that help to stabilize it and make it grow. When the resources are healthy and in full supply, the garden stays healthy across the whole surface. Think the grass, the shrubs, the soil microbes. When the resource availability drops, the symptoms show up across the surface simultaneously in places that look unrelated. The dry grass, the soil bacteria change, different plants show different kinds of stress as well. You might look at each problem in isolation and never connect them to the supplies underneath. Estrogen functions exactly like the resources in a garden for your microbiome. And your microbiome goes far beyond the large intestine. It's also present in your oral cavity, the vaginal tract, and on your skin, not just in your gut. Estrogen regulates the integrity of each and every one of these surfaces and the microbial environment across all of these sites simultaneously as well. When estrogen declines, you can see symptoms at all 4 of these surfaces that look completely unrelated and may get their own checkups, but they share a single upstream cause. Changes in body odor, for instance, often reflect changes in the skin microbiome as estrogen declines. There's also burning mouth syndrome or increased dental sensitivity that reflects changes in the oral microbiome. Also, vaginal dryness and skin dryness are all reflections of the same underlying terrain shifts in estrogen. When a woman comes to me describing 2 or 3 of these at once, the body odor, the skin changes, the vaginal dryness, I'm thinking about the hormonal supplies underneath. So instead of explaining now what's happening, let's move to explaining how to actually investigate this shift, because the investigation is more involved than most hormone conversations would suggest. The standard workup for perimenopause and determining menopause is looking at FSH, follicle stimulating hormone, which is a blood lab, and it rises as estrogen declines. It basically means the brain is trying to work harder to increase estrogen, and so its numbers go up. And sometimes they also look at estradiol, which is the primary form of estrogen in reproductive years. That snapshot tells you something, but it misses most of the picture many times. In practice, when I'm working with a woman in perimenopause whose symptoms call for a deeper look, one who's tried the hormone replacement therapy even and found only partial relief, but they want full resolution. The investigation has several layers. The first layer is processing. Estrogen is not just present or absent in your body. It moves through a multi-stage processing sequence, 3 phases of detoxification, in fact. Phase 1 converts estrogen into intermediate forms that we want to clear relatively quickly. These are the ones that are underlying conditions like hormone-dependent cancers, for instance. Phase 2 prepares those intermediates for removal, and it's largely dictated by the liver and enzymes and some of the genetics involved. Phase 3 eliminates them through the bowels. Each stage involves different enzyme function, and those enzymes are influenced again by your genetics, your nutrition, your microbiome, and your toxic or environmental burden. When phase 3 is sluggish, for instance, if you're constipated and your bowel movements are slow, bile production is compromised, or the gut microbiome is dysregulated, the breakdown byproducts of estrogen that should be leaving the body can be reabsorbed. The result is estrogen present in certain forms, in certain amounts, at the wrong time in the wrong tissues. You can see how this gets complex very fast, but that distinction matters clinically, and it rarely shows up on any standard line of questioning, aside from FSH and estradiol total numbers. The second layer is nervous system status. What is the baseline load in this woman's nervous system, and what is it carrying into the transition? What does her stress chemistry look like throughout life? Because stress hormones and sex hormones are deeply connected in the chemistry. These questions alone are often more predictive of symptom severity than the hormone levels alone. And a third layer is immune system history. Estrogen has significant effects on how the immune system calibrates its responses. As estrogen declines, some women experience immune reactivity that was previously well managed, of course, by the presence of estrogen. This can look like new conditions or autoimmunity or similar experiences. And understanding what the immune system was already doing before the hormonal shift is a huge part of reading what's happening after it as well. The fourth layer of questioning is in the bone and the muscle. Estrogen slows the breakdown of bone minerals and supports the body's ability to build and maintain muscle. These effects are real and clinically significant. They are also rarely presented alongside the neurological or the microbiome shifts, even though they are happening simultaneously and through some of the same underlying mechanisms as well. And if this is resonating with you and you'd like my eyes on your case, if you're in one of the states that I practice, the next step is to watch the free training in the description below. It prepares you to book a health mystery map call with me, and it gives you a clearer picture of whether what I do fits where you are in your healing journey. So to all of the women watching this, most of the conversations around perimenopause, whether conventional or even integrative, still organize around hormone levels as the primary variable. The belief underneath that is that more symptoms means lower estrogen, and restoring estrogen is the complete answer, this for that medicine or healing. For some women, that is true. Hormone therapy is a meaningful intervention, and I want to be clear about the fact that I support where it fits. For many women I see, the question that actually moves the investigation forward, even those on HRT, is different. It goes beyond what are my hormone levels doing, but rather what my system was already carrying and how my body even treats and processes hormones as well, even those that I'm receiving through HRT, for instance. And I have this question for you as well, and I'm genuinely curious about your experience. If you've been through the conventional perimenopause conversation, been told your labs are normal, or been offered the standard intervention, what happened when you pushed back or asked for more? What did that conversation actually look like for you? Drop it in the comments. I read everyone, and it helps other people to see their journey reflected in yours. Because what I see clinically again and again is these exact stories playing out and us not fostering open conversations about them. Hormones are often one of the last things that get deeply analyzed, and they're incredibly important. That hormone floor that sets the resilience for multiple systems, as we've explored today, should not be underestimated. Something that I see again and again is how women can walk into an appointment with a long list of symptoms and walk out with a single diagnosis that did not quite fit. And this next video is going to reframe exactly why that keeps happening, so check it out. I'm Dr. Kenny, Root Cause Health Detective. Thank you for watching, and I'll see you in the next video.